We've named this lecture after Alan Partin, who has been a big part of this meeting over the years and started it last year, and Chris Kane gave it. And this year, Dr. Klotz has been chosen to give this. I'm going to have Dr. Andrew also say a few words about Alan, since he knew him very well. I think we all did. I know that I talked to his wife, Vicki, last year after the presentation, and she showed it to Alan, who, as you may know, died from a brain tumor. And she said he responded and smiled, and it made us all feel good that was the case. So Alan we've named this lecture after him. We'll continue it as long as we can. And I heard Dr. Klotz Lori give this talk. I think it was at the ME Tech meeting and another one. I said, this is dynamite, and it deserves to have that. So Jerry, if you would come up and say a couple words, and we'll get started.
Yeah, well, I'm grateful to Mo Alof, the present head of the Brady Urological Institute at Hopkins, for some of these slides. I'm sure everybody would agree that this is a terrific portrait of Alan. He kind of looks a lot like Diamond Jim Brady, you know, and he always had that pleasant little smile on his face. I didn't know he was born in Ohio, but raised in Mississippi, and you can see he's a valedictorian, offensive lineman, All-American in the SEC, summa cum laude in chemistry in 1983, and he was accepted immediately into the MD, PhD program at Johns Hopkins under the mentorship of Don Coffey. He got his MD and PhD by 1989. He joined the faculty as an associate professor, and that implies tenure. You know, most universities now will give you 10 years to earn tenure. He got it immediately. As a resident, published 50 peer-reviewed manuscripts and wrote 7 book chapters. This quote is attributed to Joel Nelson, who was kind of a contemporary of Alan. You know, when we examine people for the Board of Urology, you're not supposed to know the name or have had any real relationship with the person you're examining, but nobody could do that for Alan because he was just so well known and so well regarded. You know, I put this slide in because David showed a few pictures of older people from times past. How many people? Who's this? Don Coffey. Who's this? Jim Moeller. Who's that? All right, there you go. That's why he's the lecturer. He got them all three. Alan Partin, H-index of 130. While he was the director of the Brady for almost 20 years, he doubled the endowment to $155 million. What's it at the University of Colorado? No, I'm going to ask you. He worked with the EDRN, the biorepository. You can see that he was a builder. You know, he established the Greenberg Bladder Cancer Institute, a Stone Center. And my involvement there for the last 2 years of my career as a urologist was to go down to Washington, D.C. and plant the flag for the Brady Institute of Urology. And if there's any young urologists in the crowd, this is where you should point your compass. These are terrific hospitals, lots of patients, fertile area for people to go. And here's a partial iteration of the awards that have been bestowed to Alan and in Alan's honor. So Dave, yeah, thanks for the opportunity to say something about Alan. He was a terrific guy and friend.
Thank you, ladies and gentlemen, and it's really a serious responsibility to give this lecture. I knew him well, admired him. If I can get my slides up. So this talk, I think, is very germane to the discussion we've been having this afternoon, because the issue of MR visibility, how do you use the MRI in conjunction with other clinical parameters, And this is a topic that is just emerging, and it's provocative, I would say. If you accept what I'm going to tell you, it does imply some changes in practice. Whoops. Another picture of Alan, and I think he would approve of my lecture. I would say he was the father of risk stratification in prostate cancer, the Partin tables. When I was in practice after a few years, this was a absolutely practice-changing area of progress to actually be able to predict the likelihood of recurrence based on clinical parameters. It didn't exist previously. That was all him. He became, at a very young age, one of the editors of Campbell's Urology, really a giant in the field. So it's a great honor to give this talk. So there's really about 3 components to this talk. The first is, why do we worry about missing invisible cancers? And the second is the genomics, and the third is the natural history of these invisible cancers. I've got some new data to show that's never been presented before from our active surveillance series vis-a-vis the impact of MR visibility. So first of all, everyone knows this, that MR does not pick up all cancers. We heard from Rob Reiter. He's got some of the best data on this from UCLA. This is a meta-analysis of about 15 studies. The likelihood of finding clinically significant prostate cancer, each of these 3 bars, total clinically significant biopsy rate, targeted in the middle, systematic on the right. So you can see there's always this delta that if you add systematic biopsies to target, you find another 15 or 20%. And the concern about invisible cancers drives a lot of interventions. It drives systematic biopsies in men having targeted biopsies. It drives systematics in men with negative imaging. Still, that is a fairly wide standard of care. It results in pushback on the concept of focal therapy, that the kind of response is, prostate cancer is multifocal. How can you treat focally? It doesn't make sense. And it drives a lot of patient anxiety in men on surveillance about this untreated occult cancer that they could have. So the key aspect of this is, what is the biologic significance? What does it mean that a cancer is not visible in MRI? Does it tell you something about the cancer? And the answer is, it tells you a lot. MR visibility is a function of size and conspicuity. I think Rob addressed some of this yesterday. The visibility is determined mainly by the tightness of cellular packing. So higher grade cancers lose the lumen, the cells are more tightly packed, water diffuses more slowly through tightly packed cells, and therefore you get restricted diffusion and a positive signal. There are some subtypes associated with lower conspicuity, particularly mucinous adenocarcinoma, which has a higher water content, but these are relatively uncommon. The message is that invisible tumors have more favorable genetics, and the implication of this is that image-based management, meaning the fact that you have occasional missed cancers that we call clinically significant, is not meaningful. This is an over-reading of the histology, and part of the evidence for this is the very favorable natural history of grade group 2. I don't have data in this talk about that, but for example, one VA study at 10 years, 4% of grade group 2 cancers managed with surveillance progressed to metastatic disease. So it's not zero, but the majority of them are indolent. So I'm now going to show a series of studies, and most of this has come out in the last 2 years. The whole field of radiogenomics is maybe 5 years old. And essentially what each study shows is that if you do very careful pixel analysis of the MRI pattern and correlate that to gene expression, which is the essence of radiogenomics, the expression of the genes that are associated with cancer visibility are the same genes that drive invasion and metastasis, or cancer aggressivity. So if you look at the bottom here, a heat map of correlation between imaging and the transcriptome. These are different ways of analyzing the pixels, and here you see EGFR, SOX9, the Decipher panel, STAT6, genes that are well known in the prostate cancer genomic area as associated with invasion and more aggressive disease, and they clearly separate out. This one was one of the first, 5 or 6 years old, and identified 4 genes that predict MRI visibility, but also predict progression-free survival and metastasis-free survival. You can see here on the right some of the gene families that are altered. The red is increased, the blue is decreased. Cell cycle regulatory genes, mitosis involved genes, growth regulatory genes. The conclusion of the paper, genes involved in cancer progression influence MR visibility. Here's another one. This is more recent. Again, like 20 different ways of evaluating the pixels, and see how this stratifies. The specific study here was hypoxia-related genes. Hypoxia, a well-known correlation between hypoxia and tumor aggressivity, and the genes associated with hypoxia differentially regulated according to the pixel pattern. This is from Rob Reiter, Nimbosis, a term that the UCLA group coined. Nimbus clouds are storm clouds. Nimbosis, genomic instability, hypoxia, and clinical aggressivity. So a kind of collection of adverse features. And MR visible tumors are enriched in the hallmarks of nimbosis. And this includes alterations with higher mutational density, and just some of the data from that study. So SHLAP1 is a is a gene that's associated with tumor aggressivity. PGA is percentage of the genome changed via copy number alteration. So there's copy number alteration, hypoxia, and you can see that these really correlate with MR visibility, PIRADS less than 3 or versus PIRADS 5. An area under the curve showing how the sensitivity and specificity of multiple components of nimbosis associated with MR visibility. This one's a little bit of a dense study, but it's quite recent and it's quite definitive. Histomic and transcriptomic features of MR visible versus invisible clinically significant prostate cancers. And essentially what this shows, there's hierarchical clustering according to visibility of the tumor. The volcano plot here showing dramatically different expression depending on visibility versus invisibility. And this is some of the genes that are altered, either increased or decreased in visible versus invisible cancers. Conclusion of this study, which is Swedish, and sampling MRI visible lesions with targeted biopsy should be sufficient for accurate risk stratification, because the invisible genes, the invisible tumors, lack the genes that are involved in tumor aggressivity. And now some clinical data to support the genomic studies. So this is a gorgeous study from Sloan Kettering, 1,449 men with significant prostate cancer having surgery. And these are the survival curves of visible is the red, PIRADS 4-5, PIRADS 3 in yellow, and PIRADS 1-2 in green. When was the last time you saw survival curves with such a massive gap between them from invisible to visible? And whether it's metastatic disease, prostate cancer mortality, essentially none of the invisible cancers progressed to metastatic disease, maybe a couple of percent, and virtually no deaths in the invisible cancers. Couple of other papers that show the same thing. This is a surveillance series, not quite as dramatic separation of the curves, but still, this is progression-free survival, time to prostate cancer treatment. In the surveillance cohort, invisible cancers dramatically more favorable than the visible cancers, and this also disaggregates them by the Gleason score. This is our data. So this is brand new. This is our fourth analysis since 2002 of this surveillance series. So we incorporated MRI into our protocol 2013, so 11 years ago. And we've got 530 men out of, now it's around 1,500 total, on active surveillance who've had at least one MRI. So we asked the question, what did it mean if their MRI was negative versus PIRADS-3 versus positive? So first of all, here's the distribution. Now this is pretty sharp contrast, for example, to the precision study we did in Canada, the PRECISE trial and the precision trial in the UK in unscreened population, where 40% had a negative MRI. In the surveillance population, 7.4% had PIRADS 1 to 2, 30% equivocal, 62%. In other words, the majority of the patients had a visible cancer. But look here how the likelihood of upgrading was predicted by the PIRADS score. 5% of the patients who had invisible cancers were upgraded to Gleason Gleason grade group 2 or higher, 34% with PIRADS 3, 52% with PIRADS 4 and 5. Dramatic difference, and no patient who had an invisible cancer was ever found to have grade group 3 or higher. With this is about roughly 10 plus years of follow-up. And this is the Kaplan-Meier. So we had 2 patients who were upgraded within the first year, and that was it. Now, some of you might say, if you only started MRI in 2013, how can you have 20-year follow-up? And the reason is that many of these patients were diagnosed years before MRI became available. They only had the MRI after they'd already been diagnosed for a number of years. We've done a sensitivity analysis, say, okay, just the patients whose MRI was in a year or two, within 2 years of diagnosis, didn't make any difference. And this is the other, I think, pretty dramatic finding from this reanalysis of our cohort. This is the metastasis-free survival stratified by pre-MRI, which is the blue, post-MRI, which is the red. We have not had a single patient with metastatic disease since we started incorporating MRI into the surveillance protocol versus about 3%, low but not zero from the years prior to that. So the message is MRI incorporated into surveillance protocol really works. And just I show one other thing, which this study was referred to earlier, I think today, maybe by Sigrid. The Jonas Hugesson screening trial. So they randomized patients at risk between targeted plus systematic versus targeted only. There were only 9 men in the targeted plus systematic who had only positive systematic, and they were all managed with, who had grade group 2 or higher, they were all managed with surveillance. So 0 patients in this huge cohort whose systematic biopsy really added anything to the targeted. This was the other side of the coin, the Meissner paper I referred to in my question yesterday, where all the patients who had positive MRI and PSMA had significant cancer. I won't dwell on that. Some further considerations about this. There's a lot of data about the patients who have positive systematic with negative targeted biopsies, suggesting it's an off-target biopsy. Most of these positive systematic biopsies come from the same side. They're ipsilateral as the target. They come from the penumbra or the shadow. And so it's probably a problem of accuracy of targeting that results in these positive systematic with negative targeted biopsies. What's the impact of all of this? If we stop doing systematic biopsies, which is basically what I think for the vast majority of patients, we're going to do 400,000 less biopsies in the United States per year, all those men with negative imaging. We're going to save a huge number of men. They'll have 3 to 6 cores of the target instead of 12 to 18. The men with on active surveillance who have negative imaging won't need any biopsies at all. And the other final point is that MRI is getting better. And I'm just going to show a couple. This is the effect of machine learning. Here's experienced radiologists. Here is machine learning of MRI. We heard something about this earlier. So machine learning seems to outperform radiologists at the moment. And then the MRI field is on fire. This is 8 different areas that are being evaluated to improve the accuracy of MR imaging. I'm not going to go into any, I'll just mention one of these called spectrum imaging, RSI, and shows the lesion much more clearly than you see with ADC. So imaging is getting better. Finally, what are the unmet needs in this area? I don't expect to convince everybody. Confirm that the uncommon, invisible, aggressive cancers will show up over time. We don't know that yet with certainty, but that's the hypothesis. The patient that Dave talked about earlier this afternoon, where his prostate's loaded with Gleason 6 with negative imaging, follow that patient. The MRI is going to become positive eventually when his disease probably becomes more genetically aggressive, and treated at that point. That's the idea. We need further analysis of the radiogenomics. It's in its infancy. We got to interrogate existing databases like Prius for more robust data on the natural history of visible versus invisible cancers. A big question is, we have other modalities, microultrasound, PSMA. What's the relationship to the whole story that I've been telling of those other modalities? What about PIRADS-3? We all struggle with that. The data we have is that they should be considered visible, but that's obviously a gray zone. And finally, what does it mean if you have a patient with grade group 1 and they have a PIRADS-5 lesion? You rebiopsy a couple of times, still grade group 1. Does that mean it has the genomics of a more aggressive cancer? I don't think anybody knows that. So to conclude, I'm trying to make the case that MR invisible lesions are genomically and clinically favorable. Even if histologically they look clinically significant, they are not. These cancers, if undiagnosed, pose little threat to the patient. Patients prefer monitoring with imaging rather than biopsy. There's no doubt about that. And there's many advantages to this strategy of image-based management in terms of burden of care, cost, the psychological benefits. You can reassure the patient, and less diagnosis of insignificant cancer. Thank you very much.
You can see why I warned Dr. Klotz about going over here, but he's forgiven. That was a great talk. But I'll ask him, do you remember who a number of years ago at this meeting told you to start getting MRI on your active surveillance patients?
It wouldn't be someone with the initials DC, would it?
It might be.
It might.
So I just want to make sure you remember that and the argument we had about MRIs and doing them on your patients. So, no, I think it's important. I don't know if I'm going to drink this Kool-Aid yet, but it is. It really is provocative, and you've got some genomic information behind it. Alan would be proud of this. Believe me, this sort of thing. Any questions for Dr. Klotz before we go? And we have a couple of abstracts to do. We're a little behind, so we're going to just do that so we can get into the trivia night, which will be a lot of fun. Okay.
I have a question for Laurie. So putting on your focal therapy or partial gland ablation hat, you have gotten an MRI. It shows a lesion in the left lower quadrant. You biopsy, it's Gleason grade group 2. The MRI doesn't show any lesions on the contralateral right posterior quadrant, and now you're set to go because either the biopsy was negative or there was one core Gleason 2, and you only need to do the left lower quadrant with your focal ablation. Would that be your conclusion from what you presented?
Well, MR underestimates tumor volume, so you've got to take that into account. But yes, that is my conclusion. You don't need systematic biopsies because the tumors that you know are going to be there, but they are indolent. And you treat with focal therapy, you still have to follow that patient essentially till they hit their dotage. So, repeat the imaging every few years. Another tumor pops up. The data suggests that If it's clinically significant, you'll see it.
So just as a contrary argument, in a wonderful study that Dave Crawford and Dr. De La Rosa and Dr. Werahera and Paula Runga and I did using mapping biopsies and MRI, the contralateral prostate, which was MRI negative, when you looked at it by quadrant, the area under the curve for clinically significant prostate cancer was 0.53. When the contralateral prostate biopsies were positive in the MRI negative zone, the average number of positive cores with Gleason grade 2 and above was 6. And so if I were going to focally ablate just the MRI visible lesion, I'm not necessarily worried about metastatic disease 10 years later. I'm more worried about confirmatory biopsies, finding positive results in 2 years, worrying about what am I going to do with the patient next, doing another treatment. So while the algorithm sounds fine, I don't think it works clinically.
So there's 2 points. One is we've got to move beyond this idea, the rubric that grade group 2 is the definition and higher is the definition of clinically significant. You think about it, there's no genomics involved in that definition, there's no imaging involved in that definition. We know most of those patients have an extremely benign natural history. So the idea is they may have, quote, clinically significant based on grade group 2 on biopsy, but in fact they're not clinically significant. And the second point is, let me just, so this is not a black and white thing. There are outliers. There are going to be, someone was telling me yesterday, maybe it was you, a grade group 9 apical cancer with negative imaging. So, those exist, but they are rare. And for that entity to drive what we're now doing, which is massive numbers of systematic biopsies, I don't think is correct.
So, okay. Well, you use the word most a lot of times, and patients don't accept the word. Most of the time, you'll do okay, and that's really the case. Dr. Murphy, okay, there are 4 people that have questions. Dr. Murphy has a question. Are you on the line? He's been anxiously waiting. Can we put him on now?
I'm here. I just had a quick comment. I saw 2 things that made me think about that. One, my own data shows that blacks have a lot more MRI blind lesions. I'm wondering if you've looked at your data by race or by age, because in the probate study, people who had higher prostate densities when they were younger tended to have MRI invisible lesions.
So I'm sorry, the audio is not terrific here. I'm not sure I understood your whole question, but as far as race, it's Canada. We have a lower proportion of African Canadians. And in this cohort, I think 5% were African Canadians in our, but that's an issue. But I think the genomic data is not something that is going to, there may be differences, racial differences in the typical pattern of gene expression, but the significance of aberrations in gene expression is going to be the same regardless of race. And I'm sorry, I didn't catch the other part of your question. I don't know if you did, Dave.
I was just asking about whether they had changed by age. I know that there are multiple reasons for having a MRI invisible lesion.
Yeah.
One example, thin peripheral zone. Another is prostatitis or fibrosis in the peripheral zone, making it harder for radiologists to see them. So I just wondered if the reason for the invisibility seemed to matter.
As far as I know, age has not come into it, but it's a question we haven't looked at.
Okay. Thank you very much. We appreciate your involvement, Adam. Okay, so we have questions. Let's make them really quick questions since they're way behind.
Laurie, congratulations. Great talk, great career.
Talk into the microphone. We haven't. I'm hard of hearing.
I asked Rob Ryder this question today in the hot tub. I wasn't satisfied with the answer. It was, how do you know with radiogenomics where you're getting your biopsy from? Because you've got the length of the core and you've got misregistration.
you're asking a question about at least 6 different studies, each one of which use somewhat different techniques for tissue collection. Some of them are based on RP, some are based on biopsy. So I actually don't, I mean, presumably the histology is confirmed. A lot of these are microdissection based. So they know that they are dealing with histologic cancer. But beyond that, I can't really answer your question. So I probably haven't satisfied you either.
Okay, John and then Paco.
We've discussed this maybe 10 years ago, but now maybe the data will change your answer. So at MD Anderson, we still face the issue of people in the community being diagnosed with PSA and trust biopsy only. So we correct that with an MRI. So in our younger age category, when, okay, there's a Pirates 5 lesion, we've offered straight up surgery if that's what they want without another biopsy because of the high degree of upgrading. If they want radiation, we usually do a fusion biopsy because that might affect ADT management. Now, I think we discussed it. You still recommended doing a fusion biopsy just to know definitively not trust the MRI completely. But this data is a lot more compelling for the beyond the surgery recurrence almost data. So what's your current thought on management of a Pirates 5 lesion in that series? Because we still can't quite get all of our surrounding.
We rebiopsy. I mean,
Sure.
there are the positive predictive value for grade group 2 or higher in our place around 90%. So there's still 10% where it's no matter how many times you keep biopsying, you don't find anything more, and so it's clearly a false positive. So, I mean, I'm not ready to abandon the biopsy in that setting, but this Meissner paper, it's 25 cases. If that was 250 cases, where 100% of the patients with positive PSMA and positive MRI had significant cancer, that is going to change practice. So I think it's evolving.
Very good. Paco.
Yeah, fascinating, the relationship of the density with MRI images, but I wanted to know if I can correlate that also in my histopathology evaluation. You were showing an icon in the areas of the invisible that were glands were separated from each other, and I see that in case cancers. But if I see areas of clusters or fusion of glands, then I will call it Gleason 4 in addition to Gleason 3. But the distance, probably that would be something very nice very easy to assess or to measure. We can do that even with very simple Photoshop, that I can evaluate the density of the glands.
Right.
Is that? Do you have any data about that?
I mean, this is beyond my kind of level of expertise, except my understanding is that all the research on MRI, that as MRI was evolved as a test for higher grade prostate cancer, there's a whole slew of studies that show that the density of cellular packing is the major determinant of restricted diffusion. So I don't know if that answers your question. I mean, some of that I'm sure is kind of quantitative analysis of the distance between glands, for example.
Yeah. That would be very important for the evaluation of the prognosis. Why do we do grading?
Right.
All right, well, we've got a lot of hardcore people here. We appreciate it. Dr. Klotz, we want to congratulate you.